Bismillahirrahmanirrahim. Assalamu alaikum. I am Professor Dr. Rafique of Medicine, Memon, Professor of Medicine in Faculty of Medicine. I hope you will be all right. Today, the second lecture on online, as there are a lot of queries that what will happen, practical and other things. Actually, we are also concerned that there must be practical clauses, but because of the government policy, we are not able to do this. And as the government permits us, we will go for the opening of the university, and then you will be having the practical classes. This is just for the theory preparation. You have to prepare yourself, and it is said that something is better than nothing. So inshallah, everything will be all right. Now today we are discussing as I mentioned previously, the problem of the thyroid. Now, as you know that thyroid gland is situated in front of the neck. There are two parts, and it's below the cricoid thyroid cartilage. Now, thyroid hormone is under control of the pituitary, and pituitary secretes TSH, thyroid hormone, and then there is a formation of the thyroid hormone T4, and then this is stored in the vesicles, thyroid vesicles, and then it is released at the time when needed, and this T4 is converted into T3. That is a more active form of the thyroid hormones. All actions are produced by the T3. Now, synthesis of the hormones, how they are formed. First of all, there is two things are important here. Iodine. Iodine is needed, and second is the tyrosine, essential amino acid. That's two things are important here. That they're essential, they're needed for the formation of the thyroid hormones. Now, what happens is that the plasma, what we eat, or sometimes there is a recirculation. When there is a deiodination, then again this iodine is used. So plasma contains iodide. There is trapping of the iodide, oxidation of the iodide, then iodination of the tyrosine and thyroid gland to form the MIT and DIT mono-minothyroxine and the di-immunothyroxine. So MIT and DIT. These form coupling. There's a coupling of the DIT and to form the T4, T3. I told you that T4 is formed in the thyroid gland. It is stored in the thyroid vesicles, and then is needed. It is released and is converted peripherally into T3. There is more active form. So these are the T4 stored in the thyroid gland, and then release of the T4 and T3 in the blood, as I told you earlier. And there is a peripheral conversion of the T4 into T3, and then again when the action is over, there is a deiodination. This again iodine tyrosine is not used, but the iodine again is used. So this is how these hormones are formed. Now, I told you that this thyroid gland is control under the control of the pituitary gland. Pituitary gland secretes the TSH, but this pituitary is again control of the hypothalamus. So there is a feedback system when the hormones are not required. The feedback system on the hypothalamus, and hypothalamus inhibits the pituitary, and the pituitary inhibits the thyroid gland. But when there is a more needed, then there is a more formation, more secretion of the pituitary TSH and thyroid hormone from the hypothalamus. Then these hormones are, there are different situations in which these hormones they needed more. Sometimes they need less. Now, what is the functions of thyroid hormone? That's more important. The physiology, you must have read it. What is function? Actually, thyroid hormone, they are called the anabolic hormones. They are essential. They have a lot of the functions. They are needed for the brain development, very important in the case. So if the patient mother has hypothyroidism, definitely the lead will produce adverse effects on the fetus. So it is essential, important that mother, if has hypothyroidism, then she must be given treatment. Then, if there is a thyrotoxicosis, then also there are a lot of problems. We discuss what problems can occur. Now, this is essential for the growth of the muscles, for the blood pressure, heart. So, this hormone actually affects every organ of the body. So, definitely the sign and symptoms of the disease will be, manifestation of the different symptom signs of almost all systems. This looks to be having the beta axon through the beta 2 agonist activity. So whatever the problems will be there, you will see that you will see discuss thyrotoxicosis. That will appear like the stimulation of the beta receptors. Now thyrotoxicosis. There are two important things here. One is the overactivity and there is underactivity. Thyrotoxicosis and hyperthyroidism, they are not same, a little bit difference. What is thyrotoxicosis? This is a goiter. Thyrotoxicosis may be goitrous, usually, or maybe non-goitrous. Now, thyrotoxicosis, it is a clinical syndrome that occurs when tissues are exposed to excess amount of the thyroid hormone. This is very important here that when the thyroid tissue are exposed to increased amount or excess amount of the thyroid hormone, resulting in specific metabolic changes and pathophysiologic alteration in the organ function, all body. So basically the syndrome. Now hyperthyroidism is just the increased level of the thyroid hormones. Hyperthyroidism is usually may be the cause of the thyrotoxicosis, but thyrotoxicosis may not be the reason of the hyperthyroidism. So in hyperthyroidism, the only values are raised, but symptoms may not be there. But here, in thyrotoxicosis, values were raised as well as the symptoms are there. So there's a difference between, there are two same terms. You must be aware of that thyrotoxicosis and hyperthyroidism, they are two different terms. The people usually think they are same, they're not same. Now, causes of the thyrotoxicosis, actually, basically, it depends what's the problem. Usually, we can divide in causes in three. There are different causes, which I am showing you here, this long list, but broadly, there are actually three. One is the grave disease, in which the diffuse goiter. Second is multinodular goiter, and third is the toxic nodule. These are the important causes. So we will be considering more on these causes. So it depends upon the increased thyroid hormone production, from where it's produced, either from pituitary or from ectopic secretion. So dependent on increased occupancy of the TSH receptor by thyroid stimulating immunoglobulin, in which two conditions are important. These antibodies are produced, so they act on the thyroid gland and produce the thyroid hormone. This is an autoimmune disorder. It's called grave disease or hashimotosis. Now, hashimotosis sometimes can convert into hypothyroidism. Then there are other ectopic secretion, human chorionic gonadotropin from the adenocarcinoma, choriocarcinoma. Then is the thyroid stimulating hormone itself from the pituitary. Now, in the other causes, uh, thyrotoxic nodule, there is an isolated nodule which becomes autonomous, active, and produces the thyroid hormone, and then now the TH producing pituitary tumors. Tumors may be autonomous production of the thyroid hormone independent of the TH. Sometimes I told you that's the toxic adenoma, toxic goiter, follicular cancer. So these are not dependent on the TSH. TSH may be suppressed, but the hormones are raised. Then dose-based effect, excess iodine induced hyperthyroidism. When some drugs containing more iodine and we are taking the more iodine. That's called Joe's best road effect, and that is temporary, not permanent. Then, independent of the thyroid hormone production, is increased thyroid hormone release. I told you that these hormones are produced and then stored in the thyroid vesicles. In some conditions, what happens is there is inflammation. There is no production, but there is inflammation of thyroid gland, and it causes more release of hormone in periphery. So this is called subacute granulomatous thyroiditis. This is painful, and subacute lymphocytic thyroiditis is painless. Now these two conditions are very important because they need not antithyroid drugs only. They need the steroids, a painkiller, anti-inflammatory, and patient delivery remains normal. Non-thyroidal source of thyroid hormone, the hamburger thyrotoxicosis. These are rare causes: ectopic production over intratrauma tumors, and then the metastatic follicular cancer. These are not so much common. So, three causes are more important: diffuse goiter, grave disease. Number two is toxic multinodular goiter, and then the single nodule toxic nodule. These are important conditions, and they need treatment differently. Now, here the pathogenesis of grave disease. These grave disease as an autonomous, without cause, antibodies are produced, and they actually act on the cells, the receptors, and produces the more hormones, more hormones. Here, what happens? The TSH is suppressed. There is from the pituitary. It's a problem basically of the problem of the thyroid gland. Now the sign and symptoms, these are the tissue specific symptoms, because I told you that thyroid gland hormone has effect on almost every system of the body. So what will be the central system, nervous effect on the central nervous system? The sign and symptoms are nervousness, emotional lability, tremors, cardiovascular palpitation, tachycardia. If it's not controlled, it can lead to the atrial fibrillation and sometimes may be permanent. Increase the difference between systolic and diastolic blood pressure. Here, systolic blood pressure is more as compared to hypothyroidism. The GI symptoms they usually have increased mortality, hyperdefecation, GI. Sometimes there are two, three conditions, important diseases in which you may consider thyroid. Like the patient has increased appetite, despite increased appetite, weight loss. So that may be the thyrotoxicosis, or apart from diabetes mellitus. In the diabetes mellitus, there is usually increased urination, but here the patient has only the loss of appetite, increased appetite and loss of weight, and unexplained diarrhea. When you cannot find any reason of the diarrhea, you may think about this thyrotoxicosis. Now the muscle, what happens? There is increased reflexia, hypermobility. Sometimes examiner asks you what are the causes of knee jerk, what are the causes of the exaggerated knee jerk. So then this may be one of the reason. Knee jerk is exaggerated, so all flexors, but usually the knee jerk. Muscle mass, there is a wasting of the muscle, atrophy. Patient may have proximal myopathy. So proximal muscle weakness, muscle atrophy, hyperplexia, muscle. Then skin warm, moist, folliculitis, fine hair, expression, excessive perspiration, sweating because of the stimulation of the vertebra. Now, symptoms of the thyrotoxicosis are very similar to the anxiety. Now, how you can differentiate? This is anxiety or this is the thyrotoxicosis? It's not necessary that all what we are discussing here, all symptoms may be present. Maybe two, maybe one. Maybe sometimes patient only comes with weakness, loss of weight. It's starting difficult to diagnose thyrotoxicosis, but when there's a full-fledged picture, you just see the patient and you can diagnose clinically, just a spot diagnosis. But sometimes we have to See, now we have to see, very important, anxiety, you have to differentiate whether it's anxiety or it's a thyrotoxicosis. The two important things are here. In thyrotoxicosis, there is lecture slide here. So important thing is that you have to differentiate between the anxiety and the thyrotoxicosis. Usually, if you go for thyrotoxicosis, warm, moist, when you shake the hand of the patient, will moist but warm. If the moist, sweaty, and cold hand, they are because of anxiety, not because of thyrotoxicosis. Then, due to metabolic heat intolerance, गर्मी बहुत ज़्यादा लगती है उसको, weight loss, usually with increased appetite, I told you. Thyroid gland, you may find enlarged nodules, or maybe multinodule, or maybe diffuse. So you have to see they are usually goiter is there. So sometimes you will appreciate the nodules, or sometimes you will not appreciate the nodules. वो जगह शो वाला है नजर को नहीं है सुन रही इधर लेक्चर से को नहीं नजर चैट किधर चैट में है कुछ हाल कुछ चैट में Bismillahirrahmanirrahim. Assalamu alaikum. Actually, there was some problem, the technical problem. That's why you are not able to see the lights. I have already discussed this problem. Thyroid, we are discussing thyroid problems with thyroid. This is thyroid gland, two lobes. So, now, as you know, the thyroid gland produces the thyroid hormone, and there's formation of the, this slide shows the formation of the thyroid hormones. So there is a plasma iodide, trapping of the iodide, oxidation of the iodide, and iodination of tyrosine thyroid gland, then coupling, and then storage thyroid gland. So these hormones are stored at T4 and some amount of T3, and then the peripheral convert when it is needed, T4 is released and it's converted into T3, which is the more active form. When there is a activity is over, again there is a deiodination, and the plasma iodide again is used for the synthesis of the hormones. Now this slide shows that there is hypothalamus, pituitary, and thyroid gland. These are under control. The thyroid gland is under control of the pituitary is under control of hypothalamus, and hypothalamus produces the thyroid-releasing hormone factor, and it acts on the pituitary release the TSH, thyroid stimulating hormone, and this acts on the thyroid gland and produces the thyroid hormones. Now, there are different problems on thyroid gland, underactivity, overactivity. We are going to discuss the thyrotoxicosis. What is the thyrotoxicosis? Now, before going to discuss the definition, I want to tell you that thyroid hormone are produced from the thyroid gland and they go to the periphery, converted into T3, and this active hormone has effect almost every system of the body. The growth of the brain, sexual activity, muscle mass, and hairs, everything, cardiovascular system, blood pressure. So this is a very important hormone. Now, thyrotoxicosis may be goitrous and non-goitrous. Usually it's the goitrous. This is a clinical syndrome that occurs when tissues are exposed to excess amount of the thyroid hormone, resulting in specific metabolic changes and pathophysiologic alteration in the organ function. So there is another term, the thyroid, hyperthyroidism and thyrotoxicosis. Hyperthyroidism, there is only increased level of the thyroid hormones, but patient may be normal. But here, thyroid hormone level is increased as well as sign symptoms will be present. So thyrotoxicosis is an exaggerated form, advanced form of the hyperthyroidism. Hyperthyroidism may be the cause of thyrotoxicosis, but thyrotoxicosis is not a cause of hyperthyroidism. Now, causes broadly you can divide into three. One is the grave disease, diffuse goiter, then toxic nodule, and then the multinodal goiter. Other forms are rare. One important form here you can see is autonomous production of thyroid hormone independent of TSH. When there is a toxic adenoma, toxic metal goiter, there is no need of it, which the TSH always suppressed. There is an autonomous production of the thyroid hormone from the thyroid gland. Then one important disease, 2, 3, they're important. They're independent of increased hormone production. If there is a hormone, it's usually normal, thyroid, TSH, not suppressed. It's normal. What happens here? That there is a inflammation of the thyroid gland, and that may be painful or that may be painless. There are two conditions. And one is the granulomatous painful, and there is the subacute lymphocytic thyroiditis is painless. Now, when there is inflammation, there is release of the hormones in the periphery, and for the temporary, it's a temporary stage, not for prolonged, maybe few days, maybe few months. So that may produce the sign symptoms of thyrotoxicosis, but TSH is normal. So treatment is different here. Here, anti-thyroid drugs are not used. This is how to pathogenesis. Now these are the antibodies are produced. Antibodies stimulate the thyroid receptors and produce these hormones. So basically, this is an autoimmune disorder, and sometimes it may go into exasperation. Sometimes it may go into burnout. Now these are the tissues specific sign and symptoms. I told you that patients can have symptom signs of the different all system almost. So now if you go for the, these symptoms may not be present in every patient, all, maybe one, maybe two, maybe three. There are certain, hints by which you can diagnose thyrotoxicosis. One is that patient may have increased appetite, loss of weight. Number two, patient may have unexplained diarrhea, unexplained weight loss. So you can think about the patient might be having this problem. The symptoms usually are just same, almost like so you have to differentiate one important thing which is very common, anxiety. More than 30% population have anxiety and depression. So this should be differentiated. The central nervous system, nervousness, emotional ability, tremors of hand, bilateral tremors, with sweating and moist hand, warm and moist hand. In the anxiety, there's moist but cold hands, so that you can easily just checking the hand of the patient, just looking to, you can easily diagnose clinically that this is thyrotoxicosis or this is the anxiety. In GIT, so in the cardiovascular, there is increased beta activity. So whether they lead to the palpitation, tachycardia, is not controlled, then it may be atrial fibrillation, increased difference between systolic and diastolic pressure. In GIT, there is increased mortality. I told you unexplained diarrhea, hepatification, GIT muscle atrophy, muscle atrophy, proximal myopathy is there, hyperreflexia, reflexes are increased. So proximal muscle weakness, muscle atrophy, hyperreflexia, skin warm, moist, smooth. I told you, the metabolic heat intolerance, weight loss, due to increased appetite. Then maybe thyroid. If you go for look for thyroid, maybe diffuse goiter, maybe palpable nodule. These are the symptoms which already I told you. But if you go for the general, again repetition, heat intolerance, hyperkinesis, fatigue, weight loss, drug intolerance, growth acceleration, central nervous system, liability, then the psychosis, periodic paralysis, tremors. In hypothyroidism, just like symptoms are depression. Here, the symptoms are just like psychosis or anxiety, because arrhythmia, palpitation, but there is increased activity. So if sometimes patient may lead to cardiomegaly and even sometimes cardiac failure, atrial fibrillation. If you go for the blood, you will find the lymphocytosis, maybe spin, may palpable. Patient may have inner cervical lymph nodes. Anemia may be there. Bone pain, accelerated episodes blur, hair fine, sweating, skin moist. Now, in grave disease, there are two other things important. One is ophthalmopathy and dermopathy. In ophthalmopathy, 5% people have periorbital edema, chemosis, ptosis, diplopia, clearing, reduced visual acuity, corneal ulcers. Then some people have dermopathy, propathy. Now, these are only have 5% people. So, this is associated with the grave disease, not another part diseases, multiple goiter or nodule. You will not find eye changes. Eye changes means there is a grave disease. So you can see now these are pictures of the patients who came here in my clinic mostly. It's a very common problem, but sometimes the diagnosis delayed and difficult. You can see here the goiter, eye changes. Although grave disease is very, in books, literature says it's more common problem of the females. But what I see in clinical practice and my personal experience, almost equal cases are there. The male, the female, goiter, diffuse goiter. You can see also the eye changes. So exophthalmos, lid lag, difficult to close eyes, you can find in the eye. More prominent here, goiter. Here you can see also the goiter is again goiter with eye changes. Now, in rare cases, thyrotoxicosis may have unilateral exophthalmos. I don't know what's the reason. Literature does not show, but here you can see there is only one eye involved. This is a young man. You'll find here goiter, goiter, diffuse goiter. Again, goiter. The resting muscles you can see here. So this is a very late arrival of the patients who has a goiter. Another person was goiter, resting. So huge goiter. Diffuse looks to be is young. Again, he has goiter. This is again young. This is goiter. This is a very typical exosal mass. You can see a resting, very typical case. It's young lady, goiter. It's goiter. It's vested. Again, eyes. It's goiter. These are all patients came to my clinic. So this is not picture from the other country. This is our population. You can see how it's common. Sometimes we feel difficulties when they have niqab or burqa, then it's very difficult to see. Sometimes cases may be missed due to this. So it's very important that the patient has palpitation, loss of weight, anything, just like symptoms of anxiety, you must check thyroid gland. Very important. All have water. Here, female. Yeah, you can see this has a typical grave disease eyes. You can see here, but most of the times we see literature you will find it's more common female, but here you can see I think almost equal number of the patients, male female, both. This again one female, state weakness. So most of the patients who come with these symptoms, different symptoms are present. Sometimes there may be problem of menstrual problems, but weakness is always present in these patients. So this should be given special consideration because weakness, it's not it's a term which is used by different people, and so many diseases can lead to the weakness. किनका? value है ना now this is diagnosis. As you know that for the diagnosis is important thing that you have to take history, clinical examination, and then you go for the laboratory diagnosis. Because this disease, without laboratory diagnosis, we cannot, laboratory investigations, we cannot diagnose this problem. So, but first of all, you have to suspicious. Really patient has thyrotoxicosis or not. And then you go for the important test. Because in examination, you may get the question about how to investigate. So three things are important here. One is thyroid hormone profile, TSH, FT4, FT3. Now I told you that in these patients, most of the cases, TSH is suppressed. FT4, FT3 is raised. But there is one condition, subacute glomerulonephritis and the lymphocytic thyroiditis, in which TSH is normal, FT3, F4 is raised. Then just know the cause. What is the cause? So we have to go for the radioisotope thyroid scan, in which you will find that if there is diffuse uptake, both both lows are involved, and if there is diffuse uptake, increased uptake of the iso compound, that is called grave disease, diffuse goiter. If there is a patchy involvement, and the rest of the gland is suppressed, that's called multiple goiter. And third is the single nodule. So this can be easily diagnosed by. And here in other disease like grammatis thyroiditis, this scan I will show the normal uptake because there is no increased activity. Basically, there is only the inflammation. Now, usually here this slide shows that if you need antibodies, TP antibodies, you can go for that. Sometimes we don't need antibodies because antibodies are treatment is same. So if you want to confirm more, then you can go for the antibodies, that is the TP antibodies. Now this slide shows that how easily the grave disease, degree of thyrotoxicosis plus 4, radio uptake is increased, enlarged gland with homogeneous uptake, I told you. Proximal goiter, there is a patchy enlarged gland with hot and cold nodules. Those are active, it will take more, cold but no uptake. So rest of the gland is suppressed. Then subacute thyroiditis mein degree of thyrotoxicosis will be there, but there will be no change. Radioactive iodine uptake will decrease and absent isotope uptake. So that will be normal. That shows there is only the inflammation. Adenoma, dominant heart nodule with low or absent uptake in the surrounding normal gland. So there's only one heart area. So that suggests there is a toxic nodule. The treatment is different that we discuss. The third test is autoantibodies. If you want to confirm, then TSH, these are the receptor antibodies or the thyroid stimulating immunoglobulin. And second is anti-TP antibodies. Yeah, thyroglobulin antibody. These are three antibodies which can be advised to confirm the patient has grave disease, because these antibodies will be raised only the grave disease, not other disease. Down nodule, other things, this will not be raised. So when you're suspecting, if your report comes diffuse goiter and values are raised, TS is suppressed, then you can also advise these antibodies for the confirmation or support of the diagnosis. Now, for the treatment is medical and surgical. Now, if patient has diffuse goiter, then we have three options. One is the drugs, antithyroid drugs, radiation therapy, and third is surgery. Now, it depends upon the patient, what patient wants. In any case, we have to use, in all cases, whatever the cause, antithyroid drugs are important. It may be due to grave disease, multinodular, or toxinodule. We have to make patient euthyroid, and then we decide further what we will do. The three drugs are available: propionate, methimazole, and carbimazole. Carburazole. Now here in Pakistan, two drugs are available: propionate and methimazole. So we can start with like because propionate tablet is 50 milligram. So at least we have to start with 300 milligram. So 100 milligram 3 times a day. And second is the carbimazole 5 milligram tablet available. So we have to start with the maximum dose. Okay. So 30 milligram, and then patient is euthyroid, we can continue 5 milligram OD. Similarly, propionate we can go for the 50 milligram maintenance dose. But patient also pushes on, what will happen? So there are three options. Either we continue these drugs for maybe 2 hours, 2 years, maybe more, in the hope that patient go into remission. अगर पेशेंट को साइड इफेक्ट्स नहीं है, दवाई लेना चाहता है, तो you can continue and see the response. But if the patient नहीं, मैं दवाई नहीं ले सकता, you go for the radioiodine therapy. Radioiodine therapy is permanent problem. If it is given, then there is the destruction of the thyroid gland, and patient may need the thyroxine throughout the life. So this should be discussed. कि भाई अगर ये इलाज होगा, लेकिन what will happen? You have to take thyroxine forever. Third is the surgery. When patient does not want medicine, if there is a respiratory problems, there is a huge goiter, diffuse goiter, and there is a cosmetical problem, then you go for a subtotal thyroidectomy. Then second is the toxic medullary goiter, in which usually is the surgery or radiation therapy. Because this disease occurs most in older group, they usually have atrial fibrillation, they are not fit for surgery, so we can advise them radiation therapy. But again, they have to take thyroxine for whole life. Third is, but before going to surgery or radiation therapy, patient have to be make euthyroid with antithyroid drugs. Third is toxic nodule, important. These three constitute about 90% causes, so they're important. And third thing, toxic nodule make patient antithyroid drug with euthyroid with antithyroid drugs, and then you have to go for surgery because there is no role of the radioiodine therapy. So I would either go for drugs, because patient will stop drug, again it will be a problem. So surgery is the choice in toxic nodule, single nodule. Remember, single nodule surgery choice. But before going surgery, you have to make patient euthyroid by antithyroid drugs. Now, other diseases like granulomatous thyroiditis, lymphocyte thyroiditis, they are autoimmune disorders for the temporary reason. So if the patient has pain and symptoms, then you go for the steroid for 4 to 6 weeks, and then stop. The patient will be perfectly all right. Now in the pregnancy, the problem can occur. What will happen? So, initially the patient could be on the anti-thyroid drugs, and later on you go for surgery, or sometimes the patient may have to take medication throughout life. Depends upon the patient choice and clinical condition. Now there is a thyrotoxicosis crisis, that is storm. Sometimes the patient stops medication, diagnosed patient, or sometimes the patient does not have an idea what is happening with him. So he has to face a lot of problems. This occurs in those patients who have thyrotoxicosis. So this is precipitated by the infection, trauma, childbirth, then radioiodine therapy. Sometimes radioiodine therapy you give. If a patient does not make the euthyroid, then this will cause release of the hormone and this cause thyroid crisis. So these are the scores which will be seen in these patients: temperature, and then tachycardia, heart failure, absent, mild is the scoring system, and then we will go for the men again diagnose the patient really has thyrotoxicosis or not, the crisis or not. So you have to see the agitation and the pedal edema, whether it crabs, pulmonary edema, and if their patient initially these symptoms are serious, delirium, psychosis, lethargy, and seizure, and finally patient go into coma. So if the coma is there, the trend score. So gastrointestinal symptoms also there. You can see they are present or absent: diarrhea, nausea, vomiting, then jaundice. And so a score of the 45 or greater is highly suggestive of thyroid storm. A score of 25, 44 is suggestive of impending storm, and a score below 25 is unlikely to represent thyroid storm. So this is scoring system. Now this is very serious form, and even going a lot of treatment, everything, the patient mortality rate is quite high. 90% people die. So treatment of direct against thyroid gland. First of all, you have to inhibit release of the hormone or formation of the hormone. So inhibition of the new hormone synthesis by drugs. These are the PTU, MMR. Inhibition of the conversion is important. Propranolol is more important here. Then corticosteroid should be given. Propranolol should be given. Now, one more important thing is here that when you start antithyroid drugs in treatment of thyrotoxicosis, you can give the beta blocker, the non-selective propranolol 40 milligram TDS to decrease the symptoms. This is not a treatment, but this is just to overcome the symptoms. So for the time being, for the drugs will be effective, you can also start this beta blocker, propranolol 40 milligram TDS in patients, whatever the reason, whatever the cause of the thyrotoxicosis. So here also we can give. Then the apodate, apomorphinic acid, amiodarone, beta blocker, propranolol, cardioselector, then removal of the excess circulation hormone, plasmapheresis. If you have facilities, you can go remove the hormone by the plasmapheresis, and then the charcoal plasma. In spite of doing this, the mortality rate is very high. So usually patient die because of this. So the best thing is that diagnose early, and we should not go this stage of the thyrotoxic process. Then the patient has high temperature, so you have to go give treatment of the hyperthermia, acetaminophen, and cooling blankets, fluids, electrolytes to be corrected, glucose, vitamins, then corticosteroid, vasopressor, and if the patient has congestive heart failure, you have to treat the diuretics. And precipitating factors are important. Etiology, what was the reason? So we have to give the treatment according to the etiology. It was infection or it was something else. So there should be given therapy according to etiology. But even I told you that despite doing all these things, patient the mortality rate is quite high. So thank you very much. This was the end of here. Inshallah, next time we will discuss the opposite form of thyrotoxicosis, that is the hypothyroidism. In against stop करो तो Indian recording. स्टाफ करना कितने शुरू से नहीं वर्ड सिलेक्ट बस स्टाफ स्टाफ काटेंगे जगह